This little guy right here is a CAT tourniquet, Combat Application Tourniquet, Generation 7, the single most battle-tested piece of hemorrhage control gear in the history of trauma medicine. Cost about $30, weight about 3 ounces. And I am about to tell you why most of the civilians I watch train with this device apply it in a way that will not actually stop arterial bleeding. There are 3 specific mistakes. If you make any one of them, the person you are trying to save will bleed out while you watch. I'm Dr. Marco. This is Talking TACMED, episode 3. Here's the problem I want to name up front. Tourniquet application is not hard. It's easy. The hard part is doing it correctly under stress. The first time. With the device, you have touched maybe twice in your life on a limb that is slippery with blood and attached to a person who is screaming. Every civilian SOFTT-W course will tell you that the tourniquet saves lives. True, the data is overwhelming. But what those courses often skip because they're trying to keep the material accessible is the 3 specific failure modes that turn a correctly purchased, correctly carried tourniquet into a useless piece of nylon. I'm going to walk you through all 3. I'm going to show you why each one happens, and I'm going to tell you exactly how to avoid them. This episode is for anyone who owns a tourniquet, carries one, or is thinking about buying one. If you do not own one yet, listen anyway, because the same principles apply to every tourniquet on the market. Now, to understand why tourniquets fail, you have to understand what they're actually doing to the body. Pressure differential. Your arteries carry blood under high pressure. In a healthy adult, systolic arterial pressure runs somewhere between 100 and 140 millimeters of mercury. Your veins, returning blood to the heart, run under much lower pressure, typically 5 to 10 millimeters of mercury. A tourniquet that generates enough compression to close a vein is not even close to closing an artery. This is the single most important physiological fact in tourniquet application. Then you have distal pulse extinction. A correctly applied tourniquet eliminates the pulse beyond the point of application. If you put a tourniquet on the thigh and you can still feel a pulse at the ankle, the tourniquet is not working. It is compressing veins and superficial arteries, but the deep arterial flow, the flow that is causing the bleeding, is still moving. This is how people bleed out with a tourniquet on. Finally, you have collateral circulation. The limbs, especially the thigh, have multiple parallel arterial pathways. A tourniquet applied with insufficient pressure may close one and leave the other one open. This is why the doctrine is not snug. The doctrine is tight enough that the patient's bleeding stops and their pulse below the device is gone. Those are the endpoints, not comfort, not the number of tensioning windlass. Bleeding stopped. Pulse gone. Now, with that physiology in hand, the 3 mistakes become obvious. Now, the CUTSy recommended tourniquets like the CAT, the SOFTT-W, the SAM-XT, the TMT, and a small number of others have all been tested to generate the pressure needed to close the femoral artery in a standard adult thigh. The device is not the problem. The application is. So, mistake number 1, too loose. This is the most common failure I see in civilian training, and even in some levels of professional training as well. The person applies the tourniquet, cranks the windlass 2 or 3 turns, sees the strap get tight, and stops. The patient is still bleeding. The person cranks harder, still bleeding. They panic, assume the tourniquet is broken, and give up. The fix is a very specific mental model. You crank the windlass until 3 things happen in order. The strap is visibly tight against the skin. The bleeding stops, and critically, you check and confirm the distal pulse is gone. If you skip the pulse check, you do not know if the tourniquet is working. The COPSI guidelines are explicit on this. Confirm pulse extinction. Mistake number 2, wand placement. The civilian instinct is to apply tourniquet as close to the wound as possible, like a pressure dressing. This is wrong for a tactical tourniquet in the pre-hospital window. The COTSI recommended doctrine is high and tight on the limb, meaning as high on the arm or leg as you can physically place it.
against the groin or the armpit. The reason is anatomical. The major arteries run deep and centrally high on the limb and distal to a major junction like the elbow or the knee. Multiple smaller arterial branches make a distal tourniquet less reliable. High and tight means you're compressing one big artery instead of trying to compress three smaller ones. And mistake number 3 is loosening it. Somewhere in the civilian first aid ecosystem, a myth persists that you should loosen a tourniquet every 15 or 20 minutes to let blood flow to the limb. This is categorically wrong. The COTSI guidelines, the Joint Trauma System Prolonged Casualty Care Doctrine, and the NASEMSO model protocols all say the same thing. Once a tourniquet is applied for life-threatening hemorrhage, it stays on until a medical provider replaces it or removes it in a controlled environment. Now, we understand that there's a concept called tourniquet conversion, but that is a little bit more advanced and outside the scope of this episode. Loosening a tourniquet in the field dumps pooled, acidic, potassium-rich blood back into a central circulation and can cause cardiac arrest. This is less than optimal. It can also restart the bleeding that you just stopped. So do not loosen it, do not adjust. Mark the time of application on the device, on the patient's forehead, and hand off. All right, so let me put you in a specific scene. You're at Home Depot on a Saturday. A man using a circular saw loses control of the tool. You don't see the contact, but you hear the sound change, and then you hear him yell. You run over, he's sitting on the floor, his right leg below the knee is open, and arterial blood is pulsing out in time with his heartbeat. Bright red, rhythmic. The floor is already slick. So what do the next 60 seconds look like for you? 0 to 10 seconds. You use your own freeze override from episode 2. You announce, you scan, you point at someone to call 911, and you kneel next to the patient. 10 to 20 seconds. You pull the tourniquet from your IFAC that we know that you're carrying, right? If you don't have one with you, you ask the crowd, loudly, specifically, does anyone have a tourniquet? It may not be a stretch in this day and age for someone to have something like a tourniquet or similar. If you don't have one, direct pressure on the wound with your dominant hand while you wait or you prep. 20 to 35 seconds. You slide the tourniquet over the foot and slide it up the leg, high and tight, as close to the groin as the injury allows. Not at the wound, high. Tighten the strap by hand as much as you can before you touch the windlass. This is called removing the slack. 35 to 55 seconds. Windlass turns, 3, 4, 5 full rotations, depending on limb size and patient musculature. You're watching the wound the entire time. The bleeding slows. The bleeding stops. You feel for a pulse at the top of the foot. Gone. You then lock the windlass. You write the time on the patient's forehead in a marker or on the time strap of the device. 50 to 60 seconds. You reassess. Is the bleeding still controlled? Is he conscious? Are you keeping him warm? Is 911 on the way? You don't loosen the tourniquet. You don't adjust it. You hand off when EMS arrives, and you tell them the time of application. 60 seconds, one tourniquet, applied correctly. You just saved the life that would otherwise have ended in that aisle. So let's talk about the 3 takeaways from this episode. 1, a tourniquet works by generating enough pressure to close an artery, which runs at roughly 120 millimeters of mercury. Venous pressure is a fraction of that. Snug is not tight enough. The endpoints are bleeding stopped and distal pulse done. 2, high and tight, not at the wound, as high on the limb as anatomy allows, compressing one major artery instead of chasing multiple smaller branches. 3, once it's on, it stays on. Do not loosen it. Do not adjust it. Mark the time, hand off to EMS, and let a medical provider remove it in a controlled environment. Finally, I built the Stop Kit IFAC around exactly this scenario. It contains one CAT Generation 7 tourniquet, or the tourniquet of your choice, one pressure dressing, one pair of chest seals, one hemostatic gauze, one regular gauze, a permanent marker, some gloves, and a laminated quick reference card with a pulse check reminder printed on it. It lives in your glove box or your backpack. It is the kit I would want a stranger to have if something happened to someone I love. Go to the link in the show notes if you want to see it. Now, next episode, we are going deeper into hemorrhage control, beyond the tourniquet. What happens when the bleed is in a place you cannot put a tourniquet on? The neck, the armpit, the groin. This is a conversation about pressure, packing, and the clotting cascade itself. Do not miss it. I'm Doc Marco, and this has been Talking TACMED. We'll catch you next time.